So I propose you to start this session with all those who are already there, and maybe some more will join us. But we have an host who is up at very early morning in Australia, so we need to start on time. So today I'm at the desk of the Clean Hospitals think tank because Alexandra unfortunately is on a sick leave. But I do want to thank her for having organizing everything and of all the jobs she's doing for the Clean Hospitals project. So it's my great pleasure and privilege to welcome today, in the early morning for some, in the late evening for the others, Professor Brett Mitchell. Professor Brett Mitchell is professor of nursing, is a teacher, he's a researcher. He has published a lot of great papers in the field of infection control on several different topics. Our field is wide. Infection control is made of a lot of things, but especially several in the field of environmental hygiene, which is the topic of clean hospitals. And maybe his masterpieces, one of his masterpieces is the REACH trial, which really helped our science to move forward and to demonstrate with a real strong randomized trial that while improving cleaning, you can decrease infection. So it's very important for us, and we do thank you for that, Professor Mitchell. Also is a real expert. He has been the chair of the 2019 Australian IPC guidelines. For those who don't know, these guidelines, they are great. And before knowing that I will share tonight, I have used this afternoon these guidelines to answer to one of my colleagues on a very special question about why for a C. diff infection, you still let isolation measures for 2 or 3 days after the end of the diarrhea. So the Australian guidelines are interesting discussion around that. I advise you to discover them. And obviously, if you don't know that also, is making with Martin Kiernan a fantastic pair of speakers or duetists with their podcast, Infection Control Matters. I love this podcast. It's a 12-minute podcast quite frequently, and you have nicely designed with funny people and very high-level scientific people, a topic often declined from papers. And at the end of last year, one of the podcasts was entitled, "Would you be admitted to a room where a previous person was infected?" And I did enjoy to hear this podcast. And this podcast was derived from a paper from Brett Mitchell, and he accepted today to present this paper and to discuss it with us after. So I see that all the mics are closed, and I will close mine after, and Brett will be really happy to hear from you.
Thank you very much, Pierre, and thank you for that lovely introduction. And thanks to everyone for joining this morning, this evening, whatever that might be for you in your different parts of the world. For me, it's a nice quiet house here at the moment because it's nice and early in the morning. So look, I just wanted to thank the Alexandra, who I know can't be here today, but just the opportunity to share this paper with you. And I'm going to run through that shortly, but the way I'm going to frame it, because it's actually not too much to talk about for that paper, is just frame that in the context of some other literature in the lead up to this paper and some of the differences that we see in clinical trial results versus sort of epidemiological based papers, which is essentially what this is summarizing. Just a couple of disclosures there, nothing of interest to this talk. So this is where I live and work in this part of Australia, just north of Sydney, for those of you who know the traditional map of Australia, or the more recent map of Australia, I should say. But for those who don't know, on the bottom right-hand side there is the traditional countries of Australia from the Indigenous population, particularly Aboriginal and Torres Strait Islander people. And Australia was made up of countless, and is made up of countless Indigenous nations. And I'm in Darkinjung country, and Darkinjung country has been looked after by the Aboriginal people on these lands for thousands of years, and I want to pay my respects to them. They've looked after these beautiful waterways. This is a couple of samples of a couple of beaches that are near me. That the one on the left is about a 10-minute drive away. In fact, I'm pretty lucky. I've got about 10 beaches that are within about 15 minutes drive. And the one on the bottom right is one of my favorite places because it's close. You can camp there. You can get some lovely walks along the coastline. It's still only about 20 minutes away from home. So it's a really beautiful part of the world here. And still not far to get to into Sydney. It's only just an hour or so away. So I work at a number of different places, including Gosford Hospital. So Gosford Hospital there on the left-hand side, and the bottom picture there's the research and clinical building that I work in as part of Gosford Hospital. On the right-hand side is the university that I also work at. So again, lovely places to work. So my chat today is going to be based on those two different things. I just want to talk about the strength of evidence around environmental cleaning. And I know this group, this is going to be nothing new, so I'm not going to harp on things that you already no doubt know. But I just want to touch on a couple of key points on that. And then I'm going to move on to the risk of prior room occupancy as a marker for the importance of cleaning, and perhaps a different way to look at that. I wanted to start by going back a few years to 2015, and many of you will probably remember this paper from Jennifer Han, and it was a technical brief, but essentially a review of what the current strategies and evidence were at that time around cleaning and its relationship with the prevention of healthcare-associated infections. And there's a couple of key points that this study identified: that there are only a handful of randomized control studies in this field, that surface decontamination was actually the main outcome observed and assessed in trials, not patient-centered outcomes. There was a real lack of comparative effectiveness studies. And future studies really should focus on new technologies, patient-centered outcomes, and where possible, infection. And that was interesting because that set the scene for a few other studies that came along post that paper. And one of the things I think we struggle with in IPC, and one of the things that I personally would like and try to do wherever possible, is to try and support us with the best quality evidence that we can have. Now, systematic reviews are great, but if we've got good trials underpinning those, randomized control studies are possible in IPC. They're not always possible, but I think we should try wherever possible to achieve RCTs with different types of RCT designs that are out there. And if we can try and provide this high-level evidence, we've got a better way of trying to provide and put forward the science of IPC, I think, into the future. And just to demonstrate that, this is a paper we did a few years ago where we reviewed infection control guidelines from around the world. This were guidelines from HICPAC, from NICE, from Canada, from Australia, Asia, APSEC guidelines. And in total, there were around 2,000 different IPC recommendations, formal recommendations in these different guidelines. We interrogated those recommendations and looked at the evidence underpinning those recommendations. And we broke down on this sort of graph, this heat map, if you like, the topics, so devices, transmission-based precautions, hand hygiene, environmental cleaning, sterilization, implementation science. And so we broke those different recommendations from across the world into those broad guidelines, into those broad topics. And then we looked at the evidence underpinning those. Now, level 1 evidence is things that we would consider to be randomized controlled studies. Level 3 would be that sort of quasi-experimental or observational-based studies. Level 7 and 8 are what we define in this paper as statutory responsibility. So There might be standards that need to be met, legal statutory requirements that have to be met. And so you can see, for example, that sterilisation fits nicely into that pocket. Where we're not going to see randomized control studies in the sterilisation field very often. So where does cleaning sit? This is cleaning, and you can see here it's really underpinned by level 3 and level 4, which was this quasi-experimental and observational based studies. So I think we had a lot of work we can do in the cleaning space to try and improve the evidence base, not just in cleaning, but in IPC generally. So fast forwarding a few years to the paper that Alexandra Peters and Didier and Pierre and perhaps others on this call were involved with, to summarize where we were at. And this, I really, really like this paper. And we got Alexandra on to talk about this paper as part of the Infection Control Matters podcast that Pierre talked about. I'm not going to rehash this paper because that's not the point of the talk, but there was some key things that I just wanted to highlight. At the time, there's still a summary that suggested that most studies around environmental hygiene examine colonization or bioburden as an outcome, some infections. And that there were a bunch of studies that did evaluate interventional-based approaches to cleaning, focusing on mechanical, chemical, human factors, and bundled approaches. Now, of the articles in this review, the authors identified 3 that were A-grade quality. That first paper there is one of John Boyce's studies looking at hydrogen peroxide. The second there is Dev Anderson's better study. And the third was a study that I was involved with, the REACH study in Australia. So just 3 that had that sort of A-grade quality assessment by the authors. So what about these high quality studies that were identified that used a true control in their work? And they wanted to assess whether there was significant reduction in microorganisms as it related to the interventions. So there were 5 studies that fit that sort of criteria, and they had 15 different outcomes across those 5 studies. 13 of those 15 studies demonstrated a reduction in either colonization and or infection. 4 of those 15 studies, and when I say studies, they're actually outcomes in those 5 studies. 4 outcomes were demonstrated to have a significant reduction in patient colonization or healthcare associated infections. So these were those studies, those 4 the 4 studies were there, and you could see Mark Wilcox for Clostridium difficile, Dev Anderson study, John Boyce, and the REACH study. Now, what do they have in common and what do they have as differences? Well, you'll notice that these are studies that showed significant reductions in colonization or infection, and where we saw that, this was primarily VRE as their outcome, by and large. In terms of the approach that they used, you'll see that there are a variety of different either approaches or products or technologies that we used to identify or associated with those differences in VRE, and one with Clostridium difficile, or Clostridium difficile, I should say. So this really doesn't help us answer some of the key questions that we have in IPC about what's the best approach, what product might be better. But what it does help us identify is that when you do improve things around IPC cleaning, it does make a difference to important outcomes like VRE, but also that most of these studies have not focused on VRE, but that's where the significant outcomes have been. So I'm going to come back to this point. So I know I've labored on this for a minute, but I'm going to come back to that point later in my talk. Now, there are different ways to look at the role of the environment in pathogen transmission. Those studies that I referred to, were clinical trials and had an intervention, and that's not always possible to do that. So there are other ways that we can look at that, and that's where I think this concept of prior room occupancy and pathogen transmission is important. And that sort of stems from this work from Axel Kramer a number of years ago, looking at survival of pathogens in the environment. And we know that pathogens can survive for quite long periods of time in the environment. Just as a side note, I've been involved in a paper that's just been accepted in JHI, and I think actually went live last night, where we've updated this review, which I think is over 20 odd years old. And so that's going to be out on JHI very shortly. But this sort of concept that pathogens can survive in the environment for a long period of time is about this sort of concept of ongoing reservoir to pose a transmission risk to someone else. And this is what I think the sort of role of prior room occupancy is an interesting marker to look at. And the concept here, of course, is that you have someone go to a room, they have a certain pathogen, they're discharged from that room, it is cleaned, whatever approach that might be. The next person enters that room. What's the risk that that next person acquires the same pathogen as the prior person, just because they went to that room or admitted to that same room? And before I sort of get into the results of the systematic review, one of the questions we did in another paper was ask nurses across Australia, would you like to be admitted to a room where the prior occupant had a multidrug-resistant organism? Now, these nurses, by and large, weren't IPC staff. These were nurses on wards. And interestingly, what they said was an overwhelming no. So our clinicians know that they probably don't want to go to a room where the last person had an MRI. Probably don't quite get why, and that's actually talked about in this paper. But it's an interesting concept that people understand that there's this risk. So this is the paper that Pierre alluded to that came out last year in Infection Disease and Health, and it was an updated review from work that we did about 10, 12 years ago. And we wanted to see whether there was any new evidence around this concept of prior room occupancy and risk, and if there were any new any changes that really had occurred in that time, noting that we've had clinical trials since that time as well. So really interested to know whether there's what the risk of an infectious organism acquisition is to the next occupant where that prior occupant had that pathogen. We were interested in studies that examined hospitalized patients, and they needed to be able to articulate that the last person did have a pathogen and identify what that pathogen was. And when they need to be able to report data on acquisition or prevalence or incidence rates for the following occupant. And we were interested in studies from 2005 through to 2021. These were the pathogens that we were interested in terms of that prior room occupancy risk. And those in yellow are ones that we updated or we included as new pathogens compared to the review that we did a number of years ago. So you can see here that there was some additional ones. Quite a bit of a mix there. We didn't deliberately search for COVID-19, and this was in the context when we were doing this updated review. We're still dealing with COVID-19, so we just wanted to differentiate that for the purposes of this study. After screening 5,000 odd articles, we ended up with 12 papers in the study. These are the 12 papers and the organisms that they evaluated. You can see by and large, the vast number there are from the United States. And the pathogens there are broad, but VRE does come up a few times, as does MRSA. The interesting thing here, there probably wasn't too many new papers. We had a new paper from Zhu, from Frankel, and Dev Anderson's paper as well, that weren't included in the review from a few years ago. So in their paper, there's a very big meta-analysis and forest plot, but I'm just going to pick out the key elements of that, because it doesn't fit very nicely into a screen. And it's pretty boring read as well. But I just want to hit some snippets of that. The first is when you combine all those pathogens together, you'll see that there is an odds ratio of 2.45, an increased risk of acquiring the same pathogen from a prior room occupant with the same pathogen. That's statistically significant. That's a very similar figure to what was in the original review a few years ago. When we break that down into looking at specific pathogens, for MRSA, there were 3 studies, and all showing the same directionality, a significant increase, significant odds ratio there, again, favouring that of increased risk. For Clostridium difficile, 2 papers there, again, showing same directionality, quite a high odds ratio there of 2.72, and the confidence interval is a bit more confined on that one too, by and large because that's influenced by a Dev Anderson study. Norovirus was one of the new pathogens that we identified in this review. Just 1 study, wide confidence intervals, and still showing the potential risk there for norovirus transmission to the next pathogen, to the next patient rather. And this is the interesting one, I thought. The other pathogens that we looked at in this study, Acinetobacter, Klebsiella, all showed, by and large, they showed increased risk. But VRE is an interesting one, because VRE, here you'll see that 2 studies did not show an increased risk for prior room occupancy. 3 studies did. And you'll see the contribution there from Dev Anderson's study is quite high too. And it really does a bit of a mixed bag. There isn't the same sort of consistent directionality that we see with these studies around VRE, and it's a non-significant result as well. Now, this is interesting because it's in direct contrast to what we see in the clinical studies that I presented and talked about at the start of the study, where we show that if you improve cleaning, it makes a difference to VRE, infection and/or colonization. But here is epidemiological-based studies, by and large, with the exception of Dev Anderson's, which isn't an epidemiological-based study. It's showing a bit of a mixed bag about that risk of ongoing transmission to the next occupant when it comes to VRE. So data from the highest quality evidence from RCT suggests that cleaning plays a role in breaking VRE transmission. Prior room occupancy data, by and large, largely quasi-experimental observational data, as I say, with the exception of Dev Anderson's study, is not as conclusive. And I think this is, we can perhaps talk about this, but for me, this is another important point about why clinical trials and randomization is very important. And we see it in other literature. Of course, observational studies would say one thing, someone does an RCT and it suggests the opposite. And so this is why I think it's really important that we wherever possible, try and aim for RCTs to inform our practice. But this is an interesting result. Now, all that said, there's lots of perhaps reasons why we see that. Of course, different study designs, but probably only describing half the story here. And a lot of the papers that have been focused on the clinical trials element have focused on either discharge cleaning or routine cleaning in the case of the REACH study. Now that's fine and great, but when you look at the detail behind some of those studies, they haven't necessarily focused on other elephants in the room as well. And those include things like shared medical equipment. And we know from genomic work that shared medical equipment has been implicated in infection transmission, particularly in the ICU setting. But it just shows that there are gaps in both those, I guess, RCTs and observational studies, and it makes some of the interpretation of this a little bit more difficult. But I think we do have a bit of an elephant in the room when it comes to shared medical equipment. It's a sort of perennial problem that everybody knows it's supposed to be cleaned between use. Everybody sort of doesn't want that responsibility. And we probably know it doesn't get cleaned very well between use. And we have the problem, of course, with clutter on wards and storage and all the other associated problems with that shared medical equipment has as well. And similarly, if we're asking clinicians to clean this stuff, we need to help them a bit more, because in work that we've done, we've asked clinical staff about how to clean these type of equipment, and do they understand concepts of contact time and what product they might use. By and large, they don't. It's a bit of a mixed bag, but they don't. So we've got a fair bit of work to do if we're expecting people to do this. So I think there's a real gap out there when it comes to shared medical equipment. So what is all this telling us? Well, I think the good news is that we have an increasing number of high quality studies showing the value of cleaning. And I think that systematic review from Alexandra and the team highlight that nicely. I think we do have strong epidemiological evidence from prior room occupancy that there's a risk. And I think that's a really useful way to sell a message sometimes. I use that in some of the hospitals that I deal with. It's a simpler concept to be able to talk about. And so I think that can be useful in terms of a communication strategy as well. And depending on, I guess, your data collection systems that people might have in hospitals, this is something that can sometimes be done locally, because we have data on who has a pathogen and does the next person acquire that same pathogen. So perhaps it can be a marker that's used to evaluate long-term trends in risk associated with environmental cleaning and infection transmission. It's not quite as complicated, but perhaps a little bit more sensitive than process-related outcomes. But I do think we also need to think about other aspects of cleaning, and that particularly is shared medical equipment. And so just before I finish, I just wanted to highlight the CLEAN study. The CLEAN study is a randomized control study that I'm leading here in Australia, and it's investigating improving the cleaning and disinfection of shared medical equipment on the incidence of healthcare-associated infections. The protocol there is being published beginning of last year. The study actually has been completed, and it was completed in November. We've analysed the data, and actually when I woke up this morning, I've just had an email from ECMED to say that it will be accepted as a late breaker for ECMED. So for those who are going to ECMED, I'll be able to share the results of this study with you, but it is be the first RCT to be able to describe the value or not of cleaning shared medical equipment when it comes to the incidence of HAIs. There might be other very good reasons why we clean shared medical equipment, but the focus of this one was looking at does it make a difference to infections. So I'm going to I'll finish up there. I'll stop sharing. Pierre, I'll hand back to you, but thanks very much everyone for listening.
Thanks really, Brett, for this presentation. So we'll wait for the clean results and to know which is the size of the elephant in the room. So it was really interesting. Thanks a lot for sharing so clearly your work and your vision. So now it's quite up to open the discussion. I've seen quickly those who are online, and we have the privilege, in addition to Professor Mitchell, to have also Professor David Kelfie and Professor John Boyce. And for me, these are the authors of the 3 best papers in the field we are working at Clean Hospitals. So it's quite great, and enjoy your evening. So you can raise your hand. Normally, I will see you and give you the mic to ask a question or share your vision or ideas. It's the think tank possibility. Just express yourself. don't be shy.
I'd be interested to hear any thoughts that people have on that, understanding the differences to why we might see in clinical trials reductions in VRE and not necessarily in epidemiological based studies.
So methodological question. Who wants to share his vision on that? So maybe if we want to start with a more basic vision, if we still have transmission with the patient, from the patient in the room before to the patient after, normally it means that our cleaning and disinfection processes are not that good. Are there other explanations? Is that the one? And is it possible in the studies to measure the quality of that, to integrate that in the parameters of calculating the risk?
I can start off on that, Pierre, if you like. Just we did look at that specifically in the first systematic review that we did on this topic, because we were thinking, okay, let's look at some of the confounders like colonization pressure, hand hygiene. Did the papers describe what cleaning practices they did? And it was such a mixed bag. Most of the studies didn't describe those sorts of elements. The sort of trials do, because they describe those things well. But when it comes to the sort of observational studies that were included in the study, there's limited information on many of them about, what impacts some of those things like colonization pressure, hand hygiene. Did they disinfect, or does it detergent? And what was their discharge cleaning process like? So there was a bit of a mixed bag for us, and we couldn't really then make any assumptions or include anything about that because it was just so heterogeneous. It was just too much heterogeneity there.
Yeah, I do agree. It's one of the limitations most of the time of the studies, to understand what has really been done in the field of cleaning or disinfecting and what people are putting behind these words. And at the time, clean hospitals are working on the lexicon, and Alexandra is leading the working group. It's not that easy to try to have a common language, and it's, to my opinion, very important. In the discussion, John Boyce asks us, can you comment on the relative importance of daily cleaning versus discharge cleaning on transmission of pathogens, and what needs to be done? So Brett, can you comment that?
Yeah, that's a great question. If only we knew the exact answer to that. But I would say my personal view is that both are critical, and I think that's been shown by work that John's done. Dev Anderson's study, and with the Better study as well, really demonstrates the importance of discharge cleaning. And then the REACH study came along, where the focus was routine cleaning and discharge cleaning, but nothing spectacular on discharge cleaning. And so I think between those studies, it shows that both make a really important contribution. Now, daily versus every other day, or daily versus twice a day, I think that's some of the nuances that we need to develop down the track. And I don't know, they're going to be exceptionally hard things to probably design and do, but I think that's probably the nuances that we need to get to down the track about what does that daily clean mean? Is there value? The first thing we often do in outbreaks is say, let's go to disinfectants, or increase the concentration of disinfectants, or we might increase it twice a day cleaning. And I think understanding the importance of that and whether it does make a difference would be really useful.
David Colfie wants to make a remark. Please, David.
Thanks. Great talk, Brett. Appreciate you sharing that with us. I guess one of the things I've been thinking about, and maybe it gets back, I don't think it explains the difference between the different types of studies, but Yeah, I don't think many of the studies have been able to assess kind of the impact of wastewater, drain contamination, and practices related to potential contamination with those wastewater sources, whether it's splashing onto the equipment. So you might clean things okay, but you still have that contamination. And can you think of a way that we can really start to address that potential when we think about the environment in some of our studies?
Yeah, that's a great question. I think we need to do a lot more work, particularly around sinks and drains. I saw an interesting paper from Mark Garvey last year looking at that sort of splash zone around sinks and thinking about the contamination risks that this might pose. And we often have a lot of equipment around sinks, unfortunately, that get contaminated. I think sinks have got a really unique opportunity, and drains more broadly, to do some work in, and we're trying to put some work together here in Australia, because I think there's an opportunity to do randomization with sinks. Now, we know sinks essentially can talk to each other through some of their drainage, but I think we do have the opportunity to be able to randomize sinks, look at different regimes to evaluate the effectiveness of things like, okay, does it matter if we clean that once a day, twice a day? What do we clean it with? Is there different types of disinfectants, foaming products that might be useful in that? What about the role of sort of the one-way valves in sinks, all those types of things? So I think there's ways that we can design sort of platform-related RCTs that could help address some of those adaptive platform designs that might help us address some of those questions in the ICU setting. I think it's going to be really hard to do that outside of those settings at the moment. I would really like to see some studies that be able to evaluate those relative contributions to some of those different approaches to drains and sinks, so we can understand which combination might be most effective in theory, and then test that in real life. And I think that's probably the couple of steps that needs to happen. But totally agree that we've got this other elephant in the room around sinks and drains and water generally.
Thank you.
Yeah, sinks is a real topic of interest in France, and obviously we have not all the studies or the good studies to say what is the best strategy, but at the time we are building new hospitals, new wards, and we have to take decision to improve things. And I think that we have already, or some have already, some knowledge about how to design water pipe, or to design things and improve a little bit before the problems arrive, because it's less expensive to anticipate than to deal with the problem when water is contaminated. And we have a lot of carbapinimas producing enterobacteria in sinks, and we suppose that it might be a source of contamination, and it's not really easy to deal with that. We put bleach, we put steams, but it's complicating and it's time consuming. So we have a question, a long question in the chat to my opinion, both Brett and David, from Emma Barrett. Emma says, great presentation. You mentioned the potential role of communication strategies in promoting the importance of cleaning in healthcare settings. Do you have thoughts on effective communication strategy that can be used to raise awareness among healthcare professionals and encourage adherence to proper cleaning practices? How can we ensure that these strategies are consistently implemented and sustained? Great challenge.
Yes, great challenge indeed. Look, this is a problem I face in my hospital, and everywhere I've worked to date, I've had this challenge, and this is the fundamental reason why I've wanted to do the clean study that I alluded to at the end of the talk, because I actually think we have to go one step back and say, we're talking, this is a different population group. These are healthcare workers who will say, where's the evidence around certain things? And so I wanted to go one step back and say, does cleaning of shared medical equipment make a difference to infection outcomes? And as I say, lots of other good reasons to do it, but that's the fundamental question. Now, if the answer to that question is yes, it enables us to have a different conversation with healthcare workers and be able to educate and communicate in a different way rather than theoretical, which I think is sometimes problematic. So that's one way that I hope we'll be able to do that. But in terms of other strategies, I think what we do need is a lot more implementation-based studies on dealing with this particular topic, and being able to understand how can we improve the adherence to cleaning of shared medical equipment or other equipment that healthcare workers might be responsible for. We've got a lot to learn, of course, from the 5 Moments of Hand Hygiene campaign, but there's probably some nuances there specifically for cleaning. So I think we've still got a lot of work we can be doing in that space around implementation. My thought first off is let's look at the science as well, but others might have different thoughts on that.
Okay, in both of your studies, for you, Brett and David, you have designed a multimodal intervention, including communication aspects, several different. For you, is it sustainable in the way you have done that for the trial? And after that, what we could do in order that to be a little sustainable? We need to reframe everything every 2 years, or what's your vision of that?
Well, I guess for the REACH study, the focus there was the sort of communication strategy and feedback loop was to cleaning staff. And I think that is sustainable, and it's been sustained in a few hospitals because the costs isn't that huge. And, we've seen that work. Phil Carling's work has, shown that with the sort of feedback from the UV dots as well. So I think that's probably sustainable, not a large impost. I don't necessarily think that's going to work. It's that same model for healthcare workers where that question I think was pitched at. So I could be wrong, maybe it will, but I'm not sure that would be sustainable, that type of model for healthcare workers. We probably need to think of a different feedback mechanism for them. And they've got so many competing demands and risks that they get fed back information on, from falls to medication errors to all kinds of things. So I think we need to think a bit more about that. Yeah.
And you, David, you have been very innovative in this field of communication in your study. What is your vision?
Yeah, and I will say that most of our work has focused on the environmental services workers, to your point, Brett, not the healthcare, the primary caregivers that are using that shared and mobile equipment. But I think you're right, the feedback does seem to be super important, and that kind of recurring, it's not just a once thing. You have to keep doing it over and over. Lots of people have shown that you kind of lose ground if you stop doing that. But I think also at the beginning, making sure people understand the importance of what it's really doing, and why, and showing them some of the data, because I think, at least for our environmental services folks, I don't think they really appreciated how important what they did was until we spent time with them talking about it. And I think just having doctors and nurses come and talk to them really helped move that group forward quite a bit, and feeling more like part of the infection control team. And I think that was probably one of my happiest moments in our whole project, was when 90-some% of them at the end in a survey felt like they were part of the infection control team. I think that helped make some of the difference as well. And at least after our intervention ended, about a year later, we still saw pretty much the same level of compliance. We were mostly focusing on that daily cleaning as well. So I think it can last with some ongoing feedback periodically and maintaining those relationships. We've tried some of that approach, more the feedback with some shared and mobile equipment, but I will say it's been fairly successful where we've done it. But we've limited it to some of the more common unit-based pieces of equipment like glucometers and EKG machines. But I think some of the things that people carry around or move around from one unit to the other might be a little bit more difficult to pull into that type of monitoring, and certainly can't monitor every piece of equipment all the time. But I do think people getting a sense, some feedback on their performance can be helpful, even in that category of equipment that's cleaned and disinfected by the healthcare worker that uses it.
Thanks a lot, David. And in addition, John said in the chat, continued direct communication between infection preventionists and housekeepers should be given greater attention, and having physicians acknowledge the importance of housekeepers. Thanks, man. Matej, you want to say something, please?
Hello, everybody. Thank you for the great discussion so far. I come from a company that is a European-based manufacturer of automated UVC disinfectors, like large devices intended to disinfect healthcare environments, of course, particularly surfaces, also air. And we see a great struggle with, you know, in the sense of communicating the advantages and also research about the effects of environmental decontamination on a high level, especially when you compare this to awareness of housekeeping stuff and everything that was said so far. So I have like a question and a thought that I would want to ask you to, you know, kind of share your thoughts on. Our communication strategies changed slightly from, you know, trying to show the evidence of, especially the published evidence of the results that our disinfection is bringing to healthcare, more to the fact that what we are effectively trying to achieve is eliminate the reason for transmission from the environment as much as we can by utilizing an automated method. You know, Professor Perencevic talked about it last year in the ICPIC about the veteran hospitals, and there was like a 20% less infections overall in hospitals that were using automated disinfection, particularly UVC, because it can be used more often than the hydrogen peroxide, for instance. There's even a study from 2015 from Napolitano that was showing a 34% reduction in overall infections when cleaning teams were using UVC, etc. So what I'm trying to say is that we don't try to prove how much we can actually prevent the infections by cleaning the surfaces, but how much infections drop if you exclude the reason for transmission primarily or predominantly from the environment. So I would want to ask you on your opinion on that approach. And on the other hand, is still related to communication strategies. In our opinion, so also the hospitals that are using our equipment are experiencing dramatic drop in transmission of particularly multidrug-resistant infections, which are so strongly connected to environmental cleanliness or disinfection. But it's very difficult to design a study and also to execute it in time and resources that will actually prove that. So how would you design such a study in order to, you know, sort of wrap up these results and try to spread the word about high-end environmental decontamination more broadly than just now when we're doing basically on foot from hospital to hospital? Thanks.
Someone want to answer? Long question, not easy.
I can wrap it up if you like. So instead of
it's okay.
It's okay. Yeah. Okay. Thanks, Pierre.
I feel it's not that easy to give you the perfect answer. What is, to my vision, what is not perfectly clear at the time the field of research is the position of disinfection compared to cleaning strategy. We have seen that we have limit in the cleaning strategies. They are never perfect, never good enough. So how could we fill or not the gap with another thing? At the time, it's not easy to evaluate that because each of the three others that I've mentioned at the beginning have made very interesting study, which shows that in the field of cleaning, we have a lot of improvement to do. If you look at the first study, 2021 of Brett Mitchell, when they asked the healthcare professional who is cleaning the bed rails, most of them don't know. And maybe it's never made or very rarely. So what is not easy in the field of hospital at the time is to say, is it possible to improve cleaning at such a level that it will be good enough to prevent transmission. The papers said quite no at the time, but the main studies show that it's possible to improve real things, the randomized control studies, and at the opposite, how could disinfection strategy and additional disinfection strategy help us? Some papers that Brett showed in the systematic review have demonstrated impact of some strategies, but it's not easy at the time to design on the daily basis, which is the perfect strategy. I don't know, man, what are your vision, Brett, if you have a vision in this field?
Yeah, look, I agree, Pierre. It's really hard to design these studies because we're really talking about something which is we now advise common, but relatively uncommon when we talk about incidents. So we often need a large number of people and/or hospitals to be able to find these relative differences, and controlling for all the other confounders is also hard. But I think you know, there's obviously sort of cluster randomized control studies are one way to help try and address some of those issues. Either clusters at ward level or hospital level. Step wedge designs are other ways. But I think, you know, one of the things I sort of alluded to, just touched on in my talk, is they're expensive and hard to do. And not everyone's going to be able to do those. And we'd love to be able to do more of them. But, you know, looking at that sort of prior room occupancy risk perhaps could be an interesting surrogate if you're going to introduce something new. New technology. Look at that. Has that risk changed over time? You know, I haven't seen many people have actually used that approach, and there's probably some problems with using that approach. But you know, that certainly you could use it, by and large, a lot of existing data to try and answer that question. So I think we do need to think quite broadly and innovatively about how we can address that. But it's a complicated issue when it comes to trying to do high quality studies in IPC.
Thanks, Brett. But obviously, we are here to discuss that and to try to improve in the future. So, Matej, you want to say something else?
Yeah, I mean, like I said, the way we approach this now is hospital to hospital, even department to department, team to team, and we try to educate them and give them a chance to try the technology. And the results are there, right? But they are not organized in a way that could be consistently used in a study or something like that. So I don't know, maybe, you know, maybe some thoughts on, I mean, we can go on like this for a while, right? But it's just a big question on how to sort of organize this in a way that not only the, should I say, innovator, community, but also the early majority will follow and give it a chance, right? And I think the core question here that we are solving is basically the human factor, right? If you exclude it out of the surface cleaning and disinfection as much as possible, because it's just so difficult to control. And there are so many other factors of transmission, of course. The surfaces are just one of the factors. The results are amazing. The question is now how to popularize that and also how to put it into scientific evidence. So I just wanted to put this on the table, you know, just to hear your thoughts. Maybe you have experience with a similar innovation, which was not used before, and it was pushed to the use bottom up. And it could be valuable to hear your experiences.
Yeah, as Brett said, and he's advocating all the time, control randomized trials are the best way to do that. So you need to design that, to think that. It's not easy. He told you about the patient before as an impact factor of your intervention, but you can read again also the John Boyce paper where he tried to analyze what should be done in order not to find results that are not correlated with the intervention. And that is really difficult. I am sure that the result that I see, the impact is really linked with my intervention. The randomized control trials could help you, but doesn't do anything. You don't do everything. You also have to think. So when I measure a contamination of a surface, does my radiation has decreased that really, etc., etc. So it's not easy. It's expensive, and it should be designed for that. But that's the reality. If you want to go further, you should make better studies and take the time and the investment on that. Otherwise, you will still go step by step, convincing people, and not other. But that's the reality. The other way to go further is to have standards of efficacy, and having a standards of efficacy of UVC disinfection on surfaces in Europe could be very helpful. There is one standard in UK, but not in Europe. So you have different approaches of doing that. But at the end, the best thing is to have a great randomized control trial, which demonstrate that the intervention is really efficient in decreasing infection. That's obvious.
I agree completely. Thank you very much.
Are there any other questions? Please do not hesitate to ask them in the chat or directly. It's better. It's even more pleasant at this time. No, everyone is happy with all that had been shared today. So no last questions. Okay. So I will thanks again a lot, Professor Brett Mitchell, for coming with us today. One question maybe. No, it's applause. It's applause, maybe. So you have applause. So I share this applause. Thanks a lot for coming today, sharing with us your expertise, your visions. Thanks also David Jones and everyone who were there. I think this format of event is quite interesting to share vision, expertise, and share also what is needed or required to progress in the future in this field. So thanks again in the name of the Clean Hospitals team to everyone, and enjoy your day or your night according to the time of the day. So bye-bye.